much, Brenda, for inviting me to give this talk. And thank you for the speakers previously for providing such an excellent background presentations to make my job a little bit easier this afternoon. We had heard earlier this morning that self-care for older adults is indeed an issue, and one key issue of aging in place is being able to manage your chronic diseases. And so today I'm going to discuss with you a randomized controlled trial that we have ongoing in Singapore that is actually testing whether education for seniors on chronic disease management can have positive outcomes in terms of reduced unanticipated hospitalization and also reduced A&E visits. This work is being done in conjunction with the Tsao Foundation, and I'm very glad to have Marianne Tsao here today. It is a unique partnership where we really are doing a private-public partnership. We are working with a steering committee that includes MCYS and AIC. Tsao Foundation is a nonprofit organization, as you know, and NUS is the academic partner. This project is also being considered as a pilot in Singapore. There are plans to roll out the same project in Indonesia next year and in Rajasthan. So there's a clear need that people are voicing in the area, in the region, for these kinds of programs. Demographic changes were covered this morning, so I won't spend too much time on that. Lower fertility, we all know, is an issue. I guess the main takeaway is that there will be fewer family members available to provide support, and this will cause a lot of difficulty for older people who are uneducated about how to manage their own conditions. So if you look at aging just generally, you'll see that although Japan is the oldest population right now, Singapore is catching up very quickly. This is a population age 65 and above. And actually, South Korea will be the second oldest population by 2050. The percentage of the population above the age of 80 is actually growing at the fastest rate. So if you want to think about a fastest population growth, you can look at this population. And then it made me wonder, after Ngee Choon's presentation, what happens after 85? So that's going to be a problem, I think, but that's a whole nother discussion. So just to add on to the fewer family members being available to provide support for older adults, there's also a situation of increased caregiver burden due to later childbearing. Individuals are having children in their mid-30s or even late 30s, which means that they're caring for the younger generation simultaneously with the older generation. And we all know from the literature that longer periods of caregiving are related to increased financial and emotional burden. So these are numbers for household size, and you can see that in 10 years we've sort of doubled in terms of the number of single-person households, and the number of two-person households has gone up from 15% to 21%. And we project these two cells to increase dramatically over time. And if you look at gender differences between, in terms of living arrangements, you see that women are more likely to be living alone compared to men. They are also more likely to live with a child compared to men, and men are more likely to live with spouses and at least one child. In terms of social networks, you see that women's social networks are slightly weaker than men's, and this, we're talking about social networks outside of the household. So women are more used to working within the private sphere as opposed to going to the public sphere and making new friends. Other implications of population aging, we're now seeing this increased dialogue on the role of the family versus the state in providing social support for older persons. There's a lot of discussion on work and retirement and burden of chronic disease, which I'm going to talk about today, end-of-life care, and a real need for evidence-based policy formulation. So part of what we're trying to do in this project is provide evidence for policymakers interested in chronic disease management. So these are some of the priorities for older persons in Singapore: maximizing family care where possible, aging in place, which is the discussion today, strengthening community-based healthcare services, and minimizing hospitalizations in institutions. But the big question is, how are we going to do this? It all sounds good, but how are we actually going to operationalize it? So our approach is a very holistic approach, and it's based on engagement of older persons, their families, and the communities in which they live in. And the project that I'm talking about specifically is SCOPE, Self-Care for Older Persons. So SCOPE is a self-care intervention program which we target healthy older people. They may have some mild disability, but as long as they're able to come down from the HDB, their HDB, to the void deck, to the senior activity center where the education is held, we will admit them into the program. We have a component that is targeted at sustainability, so we ask older people to nominate a health buddy so that once the program trainers leave, the health buddy is still going to be there and someone that the older adult can rely on, ask questions, get help from, etc. And we are also trying to evaluate the effectiveness of this idea of a community health trainer, someone who can go into the community and train older adults about chronic disease management. Is there a need for that type of person in the Singapore context? These are our indicators of success to be measured. We did some blood samples. We took some blood samples and urine samples and did some anthropometric measures in the study. So over a 36-month period, we're hoping to see a 1% decrease in HbA1c levels, an 8% improvement in hypertension, and a 10% improvement in peak expiratory flow measurements. So COPD is chronic obstructive pulmonary disease, and heart failure is one of the key causes of death in this population. In the middle, we have more of the sociology, epidemiology, psychology part of it, where we look at quality of life, and we hope that engagement with the trainers, engagement as a group, engagement with the senior activity center will improve quality of life. And we actually will look at knowledge attitudes about healthcare and follow their healthcare seeking behavior to see whether or not it improves. We're interested in building bridges and working with stakeholders, so we want to actually involve the community health trainer up to the end of the project and then conduct focus group discussions to get feedback on what the project was able to do. So a little bit of the technical stuff. The randomized control trial runs for 18 months. What happens is we have 14 senior activity centers, and they're randomized into either the control or the intervention arm. And the reason that we do this is because we can't have people in the program and not in the program in the same HDB block because of contamination issues. So we randomize by cluster, and every at baseline, 8 months and 18 months, we do a questionnaire which goes through all the sociology stuff, which I'm primarily responsible for. And then we also collect the blood markers, which gives us a little bit more objective measurement. You have to be 55 and above, and you cannot have any activities of daily living that prevent you from coming to the sessions, as I mentioned. You cannot be severely ill because our community health trainers can't handle that. And no cognitive impairment because otherwise you can't learn. And in the end, we have 200 intervention, 200 control participants. So our areas are in the north, in Ang Mo Kio. We have about 4 sites, right? The team is back there, actually. We have about 4 sites in Ang Mo Kio. And then we have another, the rest of the sites in the Bukit Merah area. And so what do the health trainers do? Well, they spend 2 hours a week working with the older adults. It's very interactive. If any of you are interested in the program, Marianne is here, and Susanna and Mian, who actually developed the modules together with some outside consultants. And the training sessions look at health promotion, disease prevention, and focused on chronic disease management. After the program is over, there's still 24 hours of support groups that occur. This is just an example of the type of blood test that we did. We did HbA1c, fasting lipid panel, albumin and creatinine, B12, full blood count, and then for those participants that agreed, we collected a DNA sample, and that's in storage. We also had the older people fill in health journals on a daily basis, and this has turned out to be actually one of the more difficult parts of the project, to get them to fill in every day what their mood is like, whether they did any exercise, whether they bought medicine, or whether they went to the A&E. But this is our way of tracking, in addition to the questionnaires, the health behavior patterns of older people. So let me give you some of the preliminary results, and then I'll end. The mean age of this population, remember I said 55 and above was our target, is actually pretty old. So our average age is 72. And that has implications for how we teach because of differences in education. We also found that 2/3 of them had elevated blood sugar levels. So 2/3 of them had blood sugar levels of 6 or above, which indicates pre-diabetic and diabetic conditions. So a lot of untreated diabetes out there. Half of them had blood pressure levels, systolic blood pressure levels, greater than or equal to 140. So anything above 140 means you have high blood pressure. But yeah, and then very, very few of them had any signs of chronic obstructive pulmonary disease, but we think that this may have been a measurement error, so we're actually going to go back and redo this again. When you look at the creatinine readings, you'll see that 43% of them had abnormal ratios, and about 6% of them had highly abnormal ratios. This means that they're spilling protein into their urine, and that's one of the first signs of kidney failure. And as you know, kidney failure is very high in Singapore. And about 40% of them had trouble with the chair stand test. We asked them to sit down and stand up 5 times as quickly as they can, and 40% of them were having difficulty. We also collected information on depression, and about 5% of them had scores that were greater than or equal to 24, which is indicative of once you hit a score of 24, that means you can be clinically depressed and you should go for actual evaluation. These are just some numbers to show gender differences in different chronic diseases like joint pain. About 26% of the female sample compared to only 13%, half, had joint pain. And hyperlipidemia was also much more prevalent among the female group. So there are significant gender differences here. I think I won't go into all of these. The other thing that we wanted to do, remember, was to increase people's knowledge and attitudes about about health conditions. And so in our baseline survey, we asked them about what they knew about hypertension. So we said, have you ever been diagnosed before? And people said no, which is in red, and then people said yes, which is in blue. And out of those that had ever been diagnosed, you'll see that half of them still had very low awareness of their condition. So they'd been diagnosed, but they hadn't really done anything about it. And why hadn't they really done anything about it? Well, this question may give us some idea. So we said, when someone's blood pressure is too high, how do they usually feel? The response categories were: don't know, have a headache and feel dizzy, have a headache, feel fine, and I don't know why. So I'll ask you guys, how many think it's have a headache and feel dizzy? How many think it's feel dizzy? Have a headache? Feel fine and don't know why it's high? Correct, is the last answer. Okay, so most people have no idea that you can have high blood pressure and it's you're basically a walking time bomb. So the other thing that we found surprising, but maybe not so surprising, was among these elderly, and they're mainly people who are in one-room apartments because they have to be connected to a senior activity center to be part of this program. Only half of them could nominate a health buddy. And so we've had to activate through Sao Foundation the use of volunteers, and possibly with HPB the use of health ambassadors to buddy up with these people, because they don't have anybody. They really don't. And so if something were to happen, they would have to become wards of the state. This project has, I should be more positive. This project has been a real good learning experience as an academic, because I think a lot of times, you know, we sit in our offices and we read all our papers and churn out results, but going to the ground and actually seeing how difficult it is to recruit people, to retain people in the project, and then to actually try and change behavior, it's just amazing. So I've really have enjoyed working on this project, and it's not over yet. And then the other thing too is culture. So having to work with the communities. We had one Malay group where one left, all 6 of them left. You know, it's like having to work with the different cultures, be respectful. This was all very, very good learning experience. So I'll end with how do we implement priorities for aging in Singapore? Well, I think the answer is really through engagement. We have to engage at various different levels. We have to educate our policymakers, older people, ourselves, and empower. So we're trying to give the power to the older person to manage their chronic disease via education and awareness. And so it's really about older persons, families, and their communities. Thank you.